Hi guys, welcome to another talk from Atoza. I'm John Mark, and in this talk, we're going to discuss emergency drugs in theatre. I remember as an intern rotating through anesthesia that it was my job to draw up emergency drugs at the beginning of the day. But I'm not sure that I fully understood the importance of the job. I'm also not sure that I fully understood what clinical scenarios called for their use or what the triggers were to administer them. In this talk, I'm really hoping to simplify this topic and give you the confidence to know how and when to use these drugs. But before we get into the specifics, let's first chat about why we have emergency drugs and what the difference is between these drugs and our routine anesthetic drugs. So, the important distinction to make is that routine drugs are part of your anesthetic plan. They're given in a planned order for a specific purpose. That is, you intend to use them. Emergency drugs, on the other hand, you really hope to not have to give it all. The key point, really, is to appreciate that emergency situations can, and do, develop rapidly in theatre, and having emergency drugs close at hand helps you manage these situations immediately. Other important thoughts to consider are: which emergency drugs need to be drawn up and ready to go? Which drugs need to be available in the theatre, but not necessarily drawn up? And which emergency drugs just need to be somewhere within the theatre complex? You might think about this in terms of how frequently the emergency scenario is encountered, how severe the emergency scenario is, and the costs of preparing and using the emergency drug. Two examples that come to mind which illustrate this are, firstly, hypotension. This occurs in the majority of anesthetics, so a vasopressor should always be drawn up and immediately available. These drugs are fairly cheap, and you are likely to use them in most cases. On the other hand, malignant hypothermia is a life-threatening emergency, but it is extremely rare, so routinely drawing up dantrolene, which is expensive, doesn't make sense. That said, you certainly want to know where it's stored and what dose you have available should you ever need it. The bottom line is this: emergency drugs don't contribute to your routine goals of anesthesia, hypnosis, analgesia, and paralysis, but rather they are there to deal with potential emergency situations which may arise rapidly and unexpectedly in theatre. You want to have a clear understanding of the role that each of these drugs play and be able to recognize the scenario that call for their use. Right. So with that in mind, let's look at these emergency drugs. And I'm going to tell you which drugs I prepare before each case to help me keep things safe in theatre. Of course, as with many things in medicine, it really depends. It depends on the patient, depends on the clinical scenario. That said, my standard emergency drugs for each case are atropine, succinylcholine, and a vasopressor, either ephedrine or phenylephrine, and often both. In addition, I always check that I have adrenaline available directly in the theatre that I'm using, and will occasionally prepare the adrenaline as either a bolus preparation or an infusion, or both, particularly in cases where I'm worried about significant cardiac instability and the potential for cardiac arrest. We'll talk more about adrenaline at the end of this talk, and I'll give you some tips on how to prepare and administer it. In the obstetric theatre, I always check that I have oxytocin, symptometrine, misoprostol, and tranexamic acid. There are numerous other emergency drugs that may be needed during an anesthetic and surgery. Every theatre complex must have a resuscitation trolley with a variety of equipment and these drugs available. The resuscitation trolley is not the topic of our talk today, but my advice would be to know where the trolley is stored, what is available on it, and whose responsibility it is to ensure that it is checked regularly and stocked. Specifically though, I want to emphasize the importance of availability of both dantrolene and intralipid directly within the theatre complex. This must be regularly checked with the dose in stock and expiry dates noted. These drugs are used very infrequently, but when they are required, you don't want to be searching through drawers and cupboards to find them, or worse still, discover they are out of stock or expired. Right. Let's now get into the details of the 3 drugs that I prepare before administering any anesthetic. These are a vasopressor, succinylcholine, and atropine. These three drugs need to be immediately available for specific, common, and potentially life-threatening situations. And these are hypotension, laryngospasm, and bradycardia. Let's start with hypotension. Hypotension is the most commonly encountered adverse effect of anesthesia, and I certainly give an inotropal vasopressor to correct hypotension in the majority of my anesthetics. Unfortunately, our commonly used induction agents and volatile agents cause vasodilation and a reduction in inotropy. This is then seen as a drop in blood pressure. The two emergency drugs that I have available to manage this scenario are phenylephrine and ephedrine. It is key to distinguish the mechanism of action of these two drugs, as well as some basic physiology. I don't want to be overly technical, but understanding this will help you remember how the drugs work and which clinical scenarios call for their use. So let's have a closer look at phenylephrine. Phenyl is a direct-acting alpha-1 adrenoreceptor agonist. So let's unpack that a little. Firstly, direct-acting means that it binds directly with the receptor. That means it does not require an endogenous intermediary. We'll contrast this with ephedrine in a moment. Secondly, alpha-1 adrenoreceptor refers to the specific receptor targeted by the drug. You'll recall from the autonomic nervous system that adrenoreceptors are the backbone of the sympathetic nervous system, and that, broadly speaking, alpha constricts and beta dilates. Think about blood vessels and airways, both pretty important for the anesthetist. Finally, phenylephrine is an agonist. This means that it causes the same effect as if your body had stimulated the receptor itself. The opposite of this would be an antagonist. Therefore, when we give phenyl, it binds directly to the alpha-1 receptor and causes the same effect as if our body had stimulated it with its own adrenaline or noradrenaline, and thus we get vasoconstriction. From this, it is logical that we administer phenylephrine when the cause of the hypotension is vasodilation, for example, neuroaxial anesthesia. If used in this situation, then the effect of the vasoconstriction is to increase the blood pressure. We'll discuss the physiology and management of hypotension in more depth in our talk on cardiovascular physiology. A few other thoughts on phenylephrine and ways to help you remember how it works. Well, we often see a drop in heart rate after we give it, and this is because it has no significant beta effect, and therefore it does not stimulate the heart. Remember, beta-1 stimulation raises heart rate. Importantly, the drop in heart rate is not a direct effect, but it's actually a reflex response to the increase in blood pressure. That is, the baroreceptors in the vasculature sense the increase in intravascular pressure, and the natural physiological response is to reduce heart rate. It's very important to remember how to prepare any drug for administration, but phenylephrine is a prime example of this. Phenyl comes in a 10 milligram amp, which is a potentially lethal dose if given undiluted. The simplest preparation is to dilute the 10 milligrams into 200 moles of normal saline, thus making a 50 microgram per mole solution. This is convenient as the usual adult dose is 50 to 100 mics per bolus, or 1 to 2 mils. Now, let's move on to the other standard emergency drug that we use to manage hypotension. This is ephedrine. I just want to mention at this point that your institution may stock Ephedrine. Think about it in much the same way as ephedrine. So, how does ephedrine actually work? Well, ephedrine is an indirect acting alpha and beta adrenoreceptor agonist. Again, I don't want to be overly technical, but understanding each of these characteristics and comparing them with phenyl will help you remember how it works, but also, more importantly, when to use it. So, ephedrine is indirect acting because it actually causes your body to release its own noradrenaline. This endogenous noradrenaline then acts on the adrenoreceptors, and because it acts on both alpha and beta receptors, you will see both an increase in blood pressure, the alpha effect, and an increase in heart rate, which is the beta effect. Like phenyl, its effect is as an agonist at these receptors. An important consideration with ephedrine is the concept of tachyphylaxis. Simply put, because ephedrine causes your body to release its own noradrenaline, this store will eventually be depleted. What this means practically is that ephedrine will become progressively less effective with each dose you give as the body uses up its stores. The general rule is to not use more than 1 amp per patient, but this is obviously time dependent. To prepare ephedrine, it comes as a 50 milligram amp. This is diluted to 10 mils with normal saline, giving a 5 milligram per mil solution. The adult dose is then 5 to 10 milligrams per bolus, or 1 to 2 mils, conveniently just like phenyl. So, how to choose between phenylephrine and ephedrine? Well, the fundamental thought for me is that it must come down to the mechanism of the hypotension. If the drop in blood pressure is purely from vasodilation, for example following a spinal, then phenyl is a good choice. For almost everything else, ephedrine is the safer choice. As mentioned, we'll discuss the mechanisms of hypotension more thoroughly in our cardiovascular talk, and this will help you identify the cause and thus the best treatment. Okay, so we've covered our first emergency clinical scenario of hypotension. Let's move on to the second emergency scenario and discuss laryngospasm. Laryngospasm is a much feared but fairly common complication in theatre. We will cover this topic more thoroughly in our talk on common emergencies in theatre, so the focus here is simply to understand why we include a muscle relaxant as an emergency drug and how to use it. The issue to understand is that if laryngospasm occurs and cannot be broken, the patient will eventually become hypoxic, and if still uncorrected, this scenario can become an arrest situation. Absolutely terrifying. The purpose of the emergency sucks is to break laryngospasm rapidly and reliably. Succinylphonium is still the muscle relaxant of choice to deal with laryngospasm, which is not broken with airway maneuvers or a propofol bolus. The drug is discussed in detail in our talk on muscle relaxants. However, the key characteristics that make it ideal in the laryngospasm scenario are its rapid onset and its relatively short duration of action. Sux comes as a 100 milligram in 2 ml ampoule, or 50 milligrams per ml. It must be kept refrigerated prior to drawing up, but once drawn up, it does not need to remain in the cold box. However, at the end of your slate, you must discard it. The dose of Sux is 1 to 1.5 milligrams per kilogram, which is the dose of an amp in an average-sized adult. For this reason, many anaesthetists draw it up undiluted in a 2 ml syringe. This helps to distinguish it from the other emergency drugs, as it is the only 2 ml syringe on the emergency trolley. We are not focusing on pediatric anesthesia in this course, as we feel peds anesthesia is an advanced technique. However, for completeness sake, and especially given that laryngospasm is common in kids, I want to mention how to prepare it for a pediatric case, as it requires some dilution. I dilute the 100 milligrams to 10 mils. This makes a 10 milligram per ml solution. This is easier to dose based on weight, as it is less concentrated. A good tip is to mark on the syringe the correct dose for the child you are anesthetizing before starting the case. Doses can be hard to calculate under pressure. Finally, on Sux, it's important to mention its use in a can't intubate, can't oxygenate scenario. Historically, it was advised to avoid muscle relaxants in these situations, but recent guidelines now advocate for it, as a paralyzed airway can assist both intubation and bag mask ventilation. Right, so we've now discussed both hypotension and laryngospasm. So let's move on to the third and final emergency situation and tackle bradycardia. Bradycardia is another relatively common emergency encountered in anesthesia, and it's the reason why we have our atropine at hand. From the start, I want to emphasize that while atropine is the treatment for bradycardia, the causes are numerous, and while it may be appropriate to administer the atropine when unexpected bradycardia is encountered, you must always aim to identify and treat the cause as well. Common causes of bradycardia you may encounter are the result of vasovagal stimuli, for example, pressure on the eye, insufflating the abdomen during laparoscopy, traction on the uterus or gonads, and many others. This is actually the ideal situation for atropine. Drug side effects or errors: succinylcholine, phenylephrine, spinal anesthesia, anesthetic overdose, both volatile and induction agent. These can all lead to bradycardia. Metabolic causes, for example, hypoglycemia or electrolyte abnormalities such as hypokalemia. Hypoxemia, as a reflex response to severe hypovolemia or a reduction in your preload, and many, many others. So, there's a lot to think about when bradycardia presents, but let's unpack how atropine actually works. Once again, this doesn't need to be overly complicated, but remembering some basic physiology will help you understand and remember how it works. As we know, the parasympathetic nervous system is largely reliant on acetylcholine as the messenger. Compare this with the sympathetic nervous system, where noradrenaline and adrenaline dominate. So, just like noradrenaline acts on alpha and beta receptors, so acetylcholine acts on the cholinergic receptors. Remember, these are muscarinic and nicotinic receptors. Atropine is an anticholinergic drug, and thus acts as a parasympathetic agent, meaning it stops the parasympathetic nervous system from slowing the heart down. If you want to be even more specific, and this helps me remember how it works, it is an antimuscarinic agent. And I mention this only to help you remember why it works the way it does. The importance being that it only acts on muscarinic receptors and not nicotinic receptors. Remember, nicotinic receptors are found in the neuromuscular junction, and you don't paralyze your patient by giving atropine. So, how do we prepare this one? Well, atropine usually comes in a 0.5 milligram amp. I dilute this to 5 moles with normal saline, and this gives me 0.1 milligrams per mole. The dose of atropine is 10 to 20 mics per kg, so in reality, this means that 1 amp isn't quite enough for the average size adult, but close enough. In peds, the dose would be 100 mics or 1 mole from the diluted solution per 10 kgs of weight. To give a practical example, a 20 kilogram child would get 2 moles from the 5 mole syringe you've prepared. This would be 200 mics. Again, best to work this out before the case to avoid having to do any maths under pressure. Bradycardia will be covered again in our tutorial on resuscitation, where we'll look at the algorithm for managing this emergency. It won't surprise you to find atropine making a star appearance there. All right, so we've now covered in some detail 3 common emergencies we may encounter in theatre: hypotension, laryngospasm, and bradycardia. I hope you're feeling a little clearer on why we draw up the emergency drugs we do, but before we finish off this talk, I just wanted to spend a little time talking about adrenaline. I mentioned it earlier, and I want to focus on it a little more to try and demystify its use. For some reason, the thought of drawing up and administering adrenaline causes a huge amount of stress and anxiety for most trainee anaesthetists. This was certainly the case for me. But before we finish off this talk, I just want to spend a little time talking about adrenaline. I mentioned it earlier, and I want to focus on it a little more to try and demystify its use. For some reason, the thought of drawing up and administering adrenaline causes a huge amount of anxiety for most trainee anaesthetists. This was definitely the case for me anyway. Perhaps this is due to its association with cardiac arrest and resuscitation scenarios, but it is well worth having some idea of the different ways to dilute and administer it, as well as which clinical scenarios may require it. So, firstly, adrenaline can be given as a bolus. This can be in a situation as serious as a cardiac arrest where multiple 1 milligram or 1 amp boluses are indicated, or it could be something as simple as using a 5 microgram bolus in place of ephedrine. The key here is appreciating the massive dosing variability. To accommodate this variation, one must understand how to dilute it. The simplest way is to take 1 amp, remembering that 1 milligram is 1,000 micrograms, and diluting it into a 10 ml syringe with normal saline. This means that each 1 ml now has 100 mics of adrenaline. This is still a potent dose and requires some further dilution. So the next step is to take 1 ml of that solution, or 100 mics, and dilute it into 20 ml with normal saline. This will create a solution where each 1 ml contains 5 mics of adrenaline. At this dose, you can give your bolus as you do with ephedrine or phenyl. In fact, A good broad rule worth knowing is that 5 mics of adrenaline is equivalent to 5 milligrams of ephedrine, which is equivalent to 50 milligrams of phenylephrine. This may help you if you ever find yourself without ephedrine or phenyl, or if you've already used an amp of ephedrine and still need a vasopressor, but you don't feel that phenyl is appropriate. So, what you now have is a 10 ml syringe with 100 mic per ml of adrenaline. This is appropriate for severe hypotension or peri-arrest scenarios. You also have a 20 ml syringe with 5 mic per ml of adrenaline, and this is appropriate for moderate hypotension. The second, more common way that we use adrenaline is as an infusion. This is a really useful technique to become confident with, as it will help you in many emergency situations, and not just in theatre. Terms to be familiar with are how the concentration is described. So, for example, you may have heard of single or double or quad strength adrenaline, but what does it all mean? Well, I think a better way to describe it is in terms of micrograms per mol, just as we have above. To do that, one has to do some simple maths. So, firstly, we must consider the dilution or strength. Remember, 1 milligram is 1,000 mics. Always describe adrenaline concentrations in terms of micrograms per mol. This makes it easier to keep communication clear and lowers the risk of making a drug error. It's convenient to dilute adrenaline into 50 ml syringes, as these are generally available in theatre, and they can be used in syringe drivers. So, 1,000 mics diluted to 50 mls means that each ml now has 20 mics of adrenaline. This is what is called single-strength adrenaline, or 1 amp. It's more common to make double-strength adrenaline. This is 2 amps, or 2,000 mics diluted to 50 mls, and this makes a 40 mic per ml solution. A more concentrated solution still would be quad-strength adrenaline, and this is when you take 4 amps, or 4,000 micrograms, diluted up to 50 moles, and this is an 80 mic per mol solution. Secondly, we must consider the rate that the infusion runs at. Clearly, the rate multiplied by the concentration will equal the actual amount of adrenaline being delivered. To simplify this, let's look at an example. 20 moles an hour of single-strength adrenaline is equivalent to a 10 mol an hour of double-strength adrenaline, which is equivalent to a 5 mol an hour of quad-strength adrenaline. My suggestion is that you standardize your dilution in the institution you work to avoid confusion and drug errors. If the anesthetists are using 40 mic per mol solutions, but the ICU team are using 80 mic per mol solutions, you can imagine how easy it is to make an error when transferring a patient. It also gives a feel for how much drug is actually required, as we all default to looking at the rate, even though we should calculate the actual dose. So, how much should we give? Well, it's a titration, and one must start the infusion and then increase or decrease to achieve the desired blood pressure goal. In general, 10 moles an hour is a reasonable start rate. I double that rate every few minutes until I get the desired response, and then I wean down slowly by 1 to 2 moles every few minutes when I'm coming off. The rule is to increase rates rapidly by doubling, but always wean slowly. Last point on adrenaline is that if the patient is unstable enough to need an adrenaline infusion, they may qualify for an arterial line and a central venous catheter. It's acceptable to start adrenaline via a wide-bore peripheral line with frequent checks, but a CVC should be placed as soon as possible to avoid damage to the vessel and the potential for tissue necrosis if extravasation occurs. I really hope that's given you a starting point for how to use adrenaline. It's really not as drastic as it seems, and often starting adrenaline early will keep you out of trouble. So, to conclude our talk on emergency drugs, I want to leave you with a couple of final thoughts. Labeling of emergency drugs is critical. You want to be as reflexive as possible without risking a drug error. There are labels available with specific colors that correspond to the action of the drug. For example, purple for vasopressors. This is a great visual cue. Other things I use to help me are syringe size. I use 10 mils for vasopressors, 5 mils for atropine, and 2 mils for sucks. Needle color and size. Location in theatre. I keep my emergency drugs on top of my anesthetic machine in a kidney dish. And pre-calculated doses marked on the syringe, especially in pediatrics. Finally, the key message I want you to take away from all of this is that we are talking about very specific situations which need to be managed with urgency. These are hypotension, laryngospasm, and bradycardia. That's it, just 3.